let Molly start us off.
Hey, so I'm Molly. I'm the one who's been chatting away about Taylor Swift. I'm the pharmacist in the breast clinic. I'll be going over the breast therapeutics, and then Dan will take over for melanoma, gyne, and sarcoma. Dan, you can go to the next slide. Here are our broad objectives. We'll be going over the mechanism of action of these therapeutics. We'll be going over rare and serious toxicities, and then going over their management and just have kind of some supportive care nuances as well. Go to the next slide. So we'll start with breast therapeutics, and then there's a duplicative slide, so same objectives. And next slide. So we'll first start with, honestly, our most popular, biggest class, our CDK4/6 inhibitors. So biggest class here, and huge, not in the sense of number of therapeutics. We do just have three here: palbociclib, ribociclib, and abemaciclib. But you're going to see them both in the adjuvant setting and metastatic setting. So you're definitely going to see this treatment quite often. In terms of mechanism, they bind to cyclin D4/6, which downstream here essentially just blocks the phosphorylation, and then DNA can't replicate, so it arrests in G1 there, and then just like halts this entire replication in its tracks and leads to cell death. You can go to the next slide, Dan. So these are our three lovely ladies. Since it's the backbone of treatment, you have these three powerhouse females in the disease state. So starting from the left there, we have palbociclib or Ibrance. It was the first on the market, and it's approved in the metastatic setting. It's super well tolerated. Unfortunately, the survival data didn't pan out, but just to the point of super well tolerated, if you have a patient with a poor performance status, this is likely where you're going to start. Ribociclib, the metastatic dosing is 600 milligrams, and then in the adjuvant setting, it's 400 milligrams. The adjuvant setting was just approved last fall in the NATALEE trial. And interestingly, just like to note, this includes no negative patients. Abema is 150 twice daily continuously, and this is metastatic and adjuvant. In adjuvant, the high-risk patients still do have to be node positive. We'll talk more about side effects and tolerability on the next slide, Dan. So in terms of tolerability, dose-limiting toxicities for palbociclib or Ibrance and ribociclib or Kisqali will be neutropenia, and then abema really is going to be the diarrhea. In the last couple months or at ASCO, there was a new trial, the TRADE trial or the TRADE study, where they looked at dose escalation with abemaciclib. So you will see that in terms of increasing just tolerability. So it's 50 BID for the first 2 weeks, 100 BID for the subsequent 2 weeks, and then starting at cycle 2, increasing to 150 BID, just trying to make it a bit more tolerable in terms of that diarrhea. For class side effects, generally minimal risk of nausea, but we do still prescribe an as-needed antiemetic. So you'll see that in our Beacon builds. We do see anemia, LFTs, and serum creatinine increases. So you'll see some organ dysfunction. It's the only one with the overall survival data in the metastatic setting. So this is often the ones that y'all are reaching for. You can go to the next slide, Dan, for our first case. So we have ML. She's a 63-year-old female with metastatic hormone positive, HER2 negative breast cancer, diagnosed earlier this year, began first-line treatment with ribo plus letrozole, and then baseline, here are her labs, and then does present cycle 1 day 15 with new labs. So again, just highlighting, we do get every 2-week labs with ribo for the first 2 cycles. And then table 2 will show dose modifications for neutropenia. So I'll stop talking so you can take a peek at those, thinking about what you'll recommend. And then Dan, if you want to go to the next slide, we'll have our answer choices there. Any ideas what you would recommend based off of her grade of neutropenia? You can shout it out or put it in the chat. If I can find the chat. Or you can shout out if we want to go back to the package insert. C. Yep. So grade 4, so pretty severe neutropenia. So certainly going to hold until it resolves, and we'll actually resume at the next lowest dose level for her just because of the severity. So you can go on to the next slide, Dan. So she resumed at the next lowest dose level, 400. Since labs revealed grade 3 neutropenia, we held the dose. She had persistent neutropenia. It took actually 4 weeks for counts to recover to grade 2. Technically, we do have another dose level that we can go down to 200. So dose levels in the metastatic setting, we have 600, 400, and 200. For this particular patient with such prolonged neutropenia and patient was not getting drug, we actually decided to switch to abemaciclib. So recognize that's always an option. We'd rather keep patient on drug than keep struggling with these dose holds. And we see generally less severe neutropenia with the abemaciclib or the Verzenio. All right, we can move on to the next slide and our next drug class. Our next drug class here is going to be the PIK3CA or AKT or PTEN inhibitors. And I kind of snuck everolimus in here with the PIK3CA and AKT inhibitors because, as you can see with the graphic, downstream mTOR inhibitors do target the same pathway. So you'll actually notice some similarities in their side effect profile. So we have alpelisib, capivasertib, and newly inavolisib. And then our mTOR inhibitor is the everolimus. So you can go on to the next slide. So just to do a quick comparison of these PIK3CA and AKT inhibitors, alpelisib is indicated for PIK3CA mutations only. It's dosed 300 milligrams by mouth once daily. Capi can be used for PIK3CA, AKT, P10. With Capi, just notice the really janky way it's dosed. It starts at 400 milligrams and recognize it's actually supplied in 200 milligram tablets. So it's 2 tablets twice daily for 4 days on and 3 days off. So thank God they finally have a blister pack for this, because even as a pharmacist, I would absolutely get this wrong. But recognize it's kind of have this broad mutation target with PIK3CA, AKT, and P10. Alpelisib and Capi are indicated after progression on endocrine therapy. So these are really hitting that second line in the metastatic disease after CDK4/6. This is in contrast to inavolisib, that's dosed 9 milligram once daily continuously, and it's actually indicated in combination with palbociclib. And remember, that's one of our CDK4/6 inhibitors, and this is actually recommended first line for patients after they've progressed on adjuvant endocrine therapy. So in the study, it was progressed on adjuvant endocrine therapy within 12 months. So like for inavolisib, it's not your like de novo breast cancer patient or metastatic breast cancer patient. And then we'll compare and contrast some of these side effect profiles on the next slide here. Dan, if you could. Thanks. Hyperglycemia across the board, we're going to dive into that in a little bit more detail on subsequent slides, but it's a class effect. Rash can be a common side effect with alpelisib and Capi, and we see some pretty severe mouth sores with inavolisib. We can see cytopenias, but typically not to the same severity as CDK4/6 inhibitors, and then we do see some organ dysfunction across the board with these agents as well. Dan, if you could go to the next slide. So hyperglycemia and rash, these are going to be the most common side effects. With hyperglycemia, certainly right out the gate, we're going to be checking A1C and fasting blood glucose prior. In the last year, Capi's package insert was updated with certainly more aggressive monitoring. We check fasting blood glucose weekly for the first cycle, just due to the manufacturer seeing increases in cases of DKA. So this is legit. And alpelisib actually has data to recommend prophylactic utility of metformin for certain high-risk patients. So you'll see that in our beacon plans as well. And then certainly, for secondary, if we're seeing hyperglycemia, we'll use metformin to treat. And always, we're trying to get better at this, but if you know a patient's going to be indicated for one of these PIK3CA inhibitors, so for example, if you're starting a patient on a CDK4/6 inhibitor, but you see PIK3CA and NGS, and then you see their A1C is like 9 and you recognize they're, not taking their metformin or any of their other anti-diabetic medications, consider at least ushering them towards their PCP to maybe optimize their anti-diabetic, because Cappy or whatever else comes out the gate is certainly going to be likely indicated for them. In terms of rash, the typical rash that does develop is a maculopapular rash, and it can certainly be pretty severe. With alpelisib, there's pretty good data to use an antihistamine to prevent rash. So you'll see that in our beacon plan, just to nip it in the bud. And we did extrapolate that, and we use it with Cappy as well. Dan, you can pop over to the next slide. Thanks. So we talked about hyperglycemia a bit here with these agents, and it's truly based on the mechanism of the drug. It's kind of this, like you hear about this on target, off tumor effect. So as you can see in this graphic, by blocking AKT or PIK3CA, it decreases skeletal and adipose tissue from being able to take back the glucose. It also inadvertently increases glucose production in the liver. So you're just really raising blood glucose kind of on all ends here. And then it does increase insulin release, but the pathway just really interferes with normal response to insulin. So you're just developing insulin resistance as well. So all in all, you're just really setting yourself up for failure in terms of insulin response. Okay, let's go to a case here. She's a 69-year-old patient with metastatic, hormone positive, HER2 negative breast cancer. She progressed on first-line therapy with Ibrance and letrozole. Her NGS shows PIK3CA, and she was started on second-line Cappy and fulvestrant. 3 weeks into therapy, she calls in to report this red maculopapular rash on her chest, abdomen, and back. So it's 45% BSA coverage. She's diagnosed with a grade 3 Cappy-induced rash. Drug is held, and patient is started on oral cetirizine and a Triam cream. You can go on to the next slide, Dan. MM's rash resolved within 2 weeks of holding, and at her follow-up visit, she restarted at the same dose. So we filed the package insert, recommended to hold. And since it resolved within 2 weeks, we went ahead and restarted the same dose. Within 3 days of restarting, the patient calls in reporting the same rash intensity. At this point, what would your recommendation be? Any ideas? I recognize this may be a little bit gray. So I would, yes, yeah, I would definitely agree with E. Yep, totally. So definitely hold drug. Yes, E's all around. So definitely hold drug, right? We want to continue cetirizine, continue Triam. Wasn't really working, but like we're not going to stop it, right? And we definitely have to escalate therapy to the prednisone, to the oral steroids. To be totally honest, not obsessed with this management in the package insert with this 28 days and then resuming at the same dose for grade 3. We had a similar patient not too long ago with rash development to grade 3 and opted to re-challenge when we to dose reduce on re-challenge. So don't feel like you're always married to this package insert, especially when we have like a newer drug. Always feel free to reach out and we can kind of go through it together. Dan, you can go ahead to the next slide. All right, next up, so moving out of the true like AKT PIK3CA options, we have everolimus. So this is our mTOR inhibitor. So old drug used in other spaces. So likely not the last time you'll see this drug. You don't need a mutation like Cappy, alpelisib, and inavolisib. Although similar to inavolisib, mouth sores can be pretty common. It's dosed at 10 mg daily. It's pretty tough to tolerate. You see GI side effects, rash, edema, and then you have metabolic side effects can be seen as well. And of course, the slew of drug interactions. So it's definitely not my favorite. So sorry, Carrie Underwood. But it is a good, oral option if you're trying to, in these hormone positive patients, keep patients out of the chemo room. Dan, you can go ahead to the next slide. We never get good supportive care trials, so when we do, we need to keep each other in the loop. Speaking of those mouth sores, the SWISH trial enrolled patients started on everolimus and actually had patients start prophylactic dexamethasone solution. So this is that Dex 0.5 mg per 5 ml oral solution, and they had patients swish for 2 minutes and spit 4 times daily, which I know is a big ask, but we'll talk how it does work, for 8 weeks to actually prevent mouth sores. And they just compared it to the original study, the Bolero trial. They found a reduction in severity and actual incidence of mouth sores. So you'll see this built into our treatment plan for everolimus. You'll actually see now in new clinical trials that are developed, you'll see patients are actually allowed to use this Dex rinse for prevention, treatment as well, although I think the benefit really is in prevention. For example, it's also recommended to use with that inavolisib. So you'll see that built into our treatment plans with that inavolisib and palbociclib plan as well. Dan, you can go ahead to the next slide. Okay, so just some other things to note with the everolimus and stomatitis. These are things you're likely already thinking about. So we have the Dex rinse to do, eat soft foods, take good care of your mouth, just things to clear, repeat to patients, soft bristle toothbrush. Um, a voodoo thing that I recommend just to warn you about so you don't think I'm totally nuts. Putting the pill in a banana or peanut butter sounds kind of goofy, but there's this thought that the pill can actually cause irritation to the mouth and esophagus. So if you hear a patient saying that their pharmacist told them to do that, I swear I'm not crazy, but there's actually some data to suggest that that can actually benefit. Things to avoid, certainly irritants to the patient's mouth, mouthwash that contains alcohol, hot liquid beverages, certainly eating foods that you're allergic to. So just being cognizant to truly being really just gentle to the patient's mouth. All right, Dan, you can go to the next slide. So moving out of that kind of class of drugs into elacestrant. So you knew we'd be talking about Taylor Swift. Elacestrant is Taylor Swift, I suppose not because it's my favorite drug, but because oral SERDs are really like the drug class of the future with a lot in the pipeline. Also, Taylor Swift is the greatest of all time. And if I could make this entire presentation about her, I would have. Anyways, elacestrant really is super cool. It binds to and degrades the actual endocrine receptor. So then, everything downstream is inhibited. So the actual gene transcription is blocked. So I guess I didn't clearly state this, but for hormone positive breast cancer, this is really going to be kind of the new cool thing for endocrine therapy. I think just another cool option. Dan, you can go to the next slide. So this is the Emerald trial that got elacestrant approved. So it's used in endocrine refractory patients. So patients must have this ESR1 mutation, which identifies patients who have some endocrine resistance. This graphic I recognize has a lot going on, but I think it describes the trial really well, where they looked at patients who are mutant for ESR1 and then wild type. And it really just highlights that the meaningful clinical response was really seen in the mutation group. Therefore, that's where the FDA approval currently lives. So elacestrant is only approved for patients who have this ESR1 mutation. Dan, you can go ahead to the next slide. So again, just to round out the conversation on this drug, for ordering logistics purposes, it's not considered chemotherapy. So common question, there's not a treatment plan for this. It's going to be ordered through the med activity. There's still some insurance barriers with this though. So if you're going to order it for a patient, definitely work with clinic on navigating this. 340 milligrams once daily continuously. So typically not too many adherence concerns. Dosage formulations and dose reductions can be a little wonky. So reach out if there's questions there. Generally really well tolerated. There's some GI considerations. We do additionally monitor lipids as well, but generally a pretty well tolerated drug. All right, Dan, you can go to the next slide. All right, so we are officially moving out of the hormone positive space, super beefy topic, but there's still quite a number of HER2 targeted agents as well, and not just limited to breast here. We have our monoclonal antibodies, our TKIs, and our antibody drug conjugates that we're going to go through. Dan, you can go to the next slide. So this is totally just a giant overview on mechanism. We're going to talk more specifically for each agent. But long story short, you have the mAbs that work externally, the TKIs that are inside the cell, and then the super cool ADCs, like I said, are really cool, and they kind of do both. So we'll talk about those. Dan, you can go to the next slide. So HER2 targeting agents are mAbs. Trastuzumab really changed the game for HER2 breast cancer. So you have, in terms of dosing, you do have the loading dose. So some considerations with the load if patient goes beyond a certain number of weeks. Always double check if they're indicated to reload. In general, super well tolerated. Keep in mind when you're looking at, side effects for these agents, most studies, it's given with other chemo agents. So if you're looking at the side effect profile and you're seeing like all these cytopenias and nausea, check yourself, recognize it's likely not coming from the trastuzumab. Pertuzumab also requires a loading dose, and it's given in combo with trastuzumab. You'll never see pertuzumab alone. I guess I should kind of reformat that. You're seeing new trials come out where pertuzumab is not necessarily always given in combo with trastuzumab. We're seeing pertuzumab given with other agents, and you'll talk about that with your providers on rotation likely, but it's never given alone, I should say. Pertuzumab's only additive side effect really is diarrhea. And we'll talk about that in a case, but we would usually drop this agent if diarrhea is like really persistent and prolonged. For both of these agents, cardiotoxicity is definitely a concern, although, reversible and we'll monitor for. We do need a baseline echo, and typically every 12 weeks, although if metastatic, there can be some, shared decision-making with the patient and really allow symptoms to guide if appropriate. Dan, you can go to the next slide there. So these clearly target the HER2 receptor, but they do hit at different areas. So trastuzumab hits the subdomain 4 and pertuzumab hits the subdomain 2, but they both lead to the inhibition of activation of HER2. So that's why we do use them together. You can go to the next slide for that. For that case. So actually, I guess not really a quiz, but we'll just walk through this together. So KL is a 41-year-old breast cancer patient beginning therapy with TCHP. So I know our T means a bunch of different things in breast cancer, but this is docetaxel, carboplatin, trastuzumab, and pertuzumab. After cycle 2, she develops grade 2 diarrhea. What are the next steps in evaluating and treating and preventing this diarrhea? So you definitely need to review the timeline with her. Was it within the first few days? That's going to likely be related more so to chemotherapy, probably more so the docetaxel, versus later in the cycle. When I say later, like more so like it could be 2 weeks into the cycle, and we're thinking more so the pertuzumab. Certainly going to get, stool studies, labs, rule everything else out, even, was it the Taco Bell? Like what else is going on during that time? Certainly if no bugs, start with the antidiarrheals, loperamide, then we can add Lomotil, then we can add the tincture of opium. And then if it's persistent, worse with future cycles, absolutely can consider discontinuing the pertuzumab. Okay, so the cool guys here, the ADCs, we have adotrastuzumab emtansine or Kadcyla. So this is our girl Beyonce. It targets the HER2 receptor, and then its conjugate, or its linker is a microtubule inhibitor, so it's cytotoxic component, so it's selectively delivered. And then we have our FAM-TRAS deruxtecan, or in HER2. It's also an ADC, so it works in a similar way. It targets HER2 with that cytotoxic component. That's a topo-1 inhibitor. The difference between these two drugs, and HER2 just has a higher payload, so a higher drug to antibody ratio. So just like more like cytotoxic molecules per antibody. So packs more of a punch. Toxicity wise between these drugs, pretty well tolerable, I suppose. Due to the cytotoxic component with each, you can see cytopenias, but not super severe. Always something to note and think about when you're seeing these patients. There is a risk of ILD and pneumonitis. And within HER2, it can be like 15 to 20% of patients, so definitely something to keep on your differential. FAM-TRAS is also highly metagenic, so you'll see all those medications built into the plans. Dan, you can go ahead to the next slide. Mechanism is super cool. So targets HER2, right? And then the tumor cell internalizes the chemo, like before it knows it, and then the cell dies. You'll hear me describe this mechanism as finding the target HER2 and then dropping off like chemo in a backpack in clinic to learners. So I think that's a cool analogy. It also has something called, on the right-hand side here, this bystander killing effect, where the payload is actually just released into the intracellular space, which isn't like, the main goal. It wants to internalize it. But in this graphic, it's pushed into the same cell, but can also release into like neighboring tumor cells just to further advance cell kill, which is really smart and really cool. Dan, you can go to the next slide. So growing list of FAM-TRAS approvals. This is like truly an ever-growing list just in the last year. So of course you're going to see HER2 positive breast cancer here. It's also indicated in HER2 low disease, so HER2 low metastatic disease. So this is going to be your IHC 1+ or 2+, where you have FISH negative. In the last year, what was added, at least in my space, was HER2 ultra low. So that's actually IHC 0, but you have membrane staining like 0 to 10%. So you'll actually see this in a comment on the path report if they're ultra low, which certainly could buy the patient an HER2 indication, which is awesome. And then you're going to see it in a wide range of other disease states as well. Dan, you can go to the next slide. So we're going to move into just our oral TKIs here. So these are the guys that work internally in the cell just to shut down further pathways. You can go ahead and move on, Dan. Thanks. So these are very popular, or not very popular, I should say, outside of just a couple regimens that do still include them. For HER2, it's great that we do see such robust data with lapatinib and tucatinib crossing the blood-brain barrier. Just to call out a couple things. Neratinib, if you don't remember anything else about these drugs, remember that neratinib can cause such significant, and I mean truly significant, diarrhea. So if you start any patients on neratinib, you'll see this in the treatment plan, but we actually have this trial, it's called the control trial, that compared different strategies for diarrhea prevention. So in the plan, you'll notice we have a dose escalation built, and that's on the slide here with the ramp. But we actually schedule loperamide for the first 2 cycles, and additionally, we consider adding cholestyramine as well. Neratinib is a bit different than lapatinib and tucatinib, where those two are only utilized in the metastatic space. Neratinib can additionally be used in the adjuvant setting as well for a year in high-risk patients. So a little bit differing in indication too. Class effects in terms of side effect profiles. We can see some additional skin toxicities. As noted, we talked about some of the GI effects in terms of nausea and vomiting. We can see some cytopenias, typically not as severe as the CDK4/6 inhibitors or things that we've already talked about, though. Dan, you can go on to the next slide. So this is sacituzumab govitecan, or Trodelvy, or Saucy G is a pretty cute nickname we have for this drug. This is another drug antibody conjugate in a way. So the antibody binds to TROP2. Then inside the cell, that cytotoxic portion of the drug leads to further, DNA damage and cell death, as you can see in this infographic, the cell death. Dan, you can go on to the next slide. Thanks. So it's dosed 10 mg per kg IV on days 1 and 8 of a 21-day cycle. This is indicated actually both in the triple negative breast cancer space and hormone positive HER2 negative metastatic space, both needing to receive prior lines of treatment. So as I had mentioned, how it works earlier, it binds to TROP2, it's internalized, and then SN38 is that cytotoxic component, which leads to DNA damage and cell death. It's actually a fair amount of side effects in terms of tolerability. We do see neutropenia, thrombocytopenia. It's highly emetogenic. We do have some pre-meds for this. We can see some infusion-related reactions. GCSF with Saucy G is kind of been a hot topic this past year. We've historically reserved it for secondary prevention just due to goals of care in the metastatic setting. But the pharmaceutical company, really without any further safety data, did urge utility as primary. So we've been taking that into consideration when reviewing patient factors for neutropenia when we start Saucy G. So keep that in mind, if you have a patient with poor performance status, maybe clearly multiple lines of treatment, we can discuss adding it as primary prophylaxis too. Dan, you can go to the next slide here. So my last question, what other chemotherapy agents has the metabolite SN38? B, yes. Yep. So irinotecan. So thinking diarrhea is the main culprit with irinotecan or under the can, we can see quite a bit of diarrhea with Saucy G. So yep, that's going to be the culprit. All right, I think that was my last slide. Any questions for me? I'll stay on and maybe we can do questions at the very end. But thanks for listening.
Okay, thanks, Molly. I'll be taking over for the next few sections. My name is Dan. I'm one of the clinic pharmacists as well, and I practice in our melanoma, sarcoma, and gyn-onc clinics. So we'll next talk about some targeted agents in melanoma. So we've got some spice with our BRAF and MEK inhibitors. We use these in melanoma, and these days we always use these drugs together. Initially, we had looked at BRAF and MEK individually, but we find that as we have this continuous pathway of activation in our BRAF mutants, if we are only blocking MEK or only blocking BRAF, we can see sort of an escape pathway being utilized. So I often will use the analogy of penicillins and our beta-lactamase inhibitors, where these things are working synergistically so that we don't have resistance pathways that develop within the cell. But in the melanoma space, these are indicated for BRAF mutated ones. So we've got 3 combinations: dabrafenib, trametinib, vemurafenib, cobimetinib, and encorafenib and binimetinib. So we have our dosing listed here. No super exciting things to really say about the dosing regimens, other than we do have drug interactions across the board with all of these, so we have to make sure that we're screening for that ahead of time. Some interesting side effects, though. For dabrafenib and trametinib in particular, we can see fevers, and we do see that with some of the other BRAF inhibitors as well, but with much decreased frequency. Usually, this is more of a dabrafenib focused side effect. And with those fevers, if we hold drug, generally they will resolve and we can re-challenge, and many folks don't have recurrence of those fevers. Class effects, though, for this is going to be effects on the skin. So we can see thickening of the calluses on soles of the feet, palms of the hands, and then diarrhea is also pretty common across this group. And then for our more serious side effects, all of our BRAF MEK combinations can have impacts on cardiac health. So we need to be watching echoes and making sure that cardiac function is staying strong. So this sort of looks at sort of variations of side effects we can see with these, and what we might use to treat that. So we have sort of the intensity going up. For example, with our rash, we might just start with emollients and moisturizers, but if skin rash is getting worse, we might escalate to topical glucocorticoids, maybe some antibiotics like a doxycycline. But the rash can be all the way up to very severe forms like Stevens-Johnson syndrome, though that is rare. And sort of we would increase the intensity of our intervention for the intensity of that side effect. So let's think about a case related to a melanoma patient. MJ is a 39-year-old with stage 3B BRAF mutated resected melanoma, and she began adjuvant therapy with dabrafenib and trametinib. I'm calling her to follow up 1 week after starting therapy, and she informs me that she's only been taking one capsule of her dabrafenib twice daily. And that is a very common thing that can come up with any of our BRAF MEK inhibitors. They all have multiple tablets that people are needing to take. And when we're having two different drugs, that's two different sets of instructions that can be very difficult for patients to manage. So adherence can be challenging with oral chemos. When people are in the clinic getting in their vein, we have control over all of that. But when they're at home, we need to rely on patients. So that means that we need to give them good education up front on sort of these complex dosing schemes. She comes back to clinic 5 months later after starting therapy and reports that she's developed itchy, bumpy red rash on her torso, face, legs, and upper arms. It's covering almost 90% of her body. So what are our treatment options here for what we should do? And I will accept more than one answer. Well, I think first and foremost, we need to stop the drug. She has 90% coverage of this rash. So yes, I think we could pretty much do almost any of these, honestly, because we need to stop the drug because it's the cause of this rash. With that level of coverage, we're probably going to want some topical and oral steroids to help calm the skin down. And she's probably pretty itchy, so let's give her some hydroxyzine for some symptom relief. So the correct answer was the secret fifth answer of E, all of the above that I didn't actually give you. So oftentimes with these complex adverse reactions, we do need to do multiple things. So her rash does eventually resolve and she comes back to clinic a month later, and she does a reduced dose. 1 week after restarting, though, she calls in and reports a fever that's been happening every day, all the way up to almost 103 degrees. So what do we think is the cause of this fever? I'm hearing some A's in the chat. So yep, that is correct. Dabrafenib is very notorious for causing drug fevers. So that is the most likely cause here. So we'd probably have her hold, and more than likely, those fevers will resolve pretty quickly. So let's move to a more niche agent, tebentafusp, or Kimtrac. This is a very unique agent. It's essentially a bite therapy, but it's not a monoclonal antibody. It's a fusion protein. But sort of this is one of the bites. We actually had them in solids before heme had them, but we sort of snuck them in with tebentafusp. We don't see this very often because it's only indicated for uveal melanomas or melanomas of different structures of the eye. And it's only indicated in the setting of HLA star 0201 positivity. So like most of our bites, this is engaging the immune system as well as sort of bringing it right to that tumor cell. So the hope is that we will have that activated T cell right next to the tumor cell so it can do its work and get to that natural killing. But much like with our other bite therapies, we can see CRS, risk for hypotension, and skin reactions and elevations of LFTs can occur as well. So with this agent, much like other bite therapies, we have this ramp of the dosing. So day 1 is a 20 microgram dose, day 8 is 30 micrograms, and then day 15 is our first full treatment dose. And those first 3 doses do have to be given inpatient so that we can monitor for hypotension and treat accordingly. So again, we talked about sort of that bite mechanism, bispecific engagement, where we have that HLA expression on the uveal melanoma site, and then we have sort of the tail end of that molecule pulling that T cell in and activating it so it knows where it should be doing its job. So that rounds out our melanoma targeted therapies, and we'll move next into gyn-onc. So actually used in many, many different disease states, but as your gyn-onc pharmacist, I'll speak to them more in a gyn-onc perspective. But we have olaparib, niraparib, talazoparib, and rucaparib with their different approvals listed there. The mechanism here is that poly-ADP ribose polymerase, or PARP, is usually working to prevent DNA damage and repair those things. So when we inhibit that, those single-strand breaks stick around for longer and then result in cell death. BRCA mutated cells are particularly bad at correcting those single strand breaks. So when we're blocking that PARP from fixing those, we see that BRCA mutated cells are more sensitive to these PARP inhibitors. We also have the idea of this homologous repair functionality. And we also, in some disease states, will check that HR status, sort of a similar biological situation to a BRCA mutation. HR status can also reflect more sensitivity to the actions of PARPs. If someone is HR or a tumor is HR deficient, it is not as easy to fix those breaks in DNA and is therefore more sensitive to the action of that PARP inhibitor. And then subsequently, those patients are more likely to benefit from a PARP. So depending on sort of which disease state, we might check for BRCA status, we might check for HRD status, or some of these are approved for all comers, depending on those indications. So I'm going to focus on olaparib because that's the one that we use the most of in gyn-onc, and I will sort of use that as an example case because a lot of these side effects are class effect. Nausea and vomiting can occur with these, but I would say the most sort of common side effect that patients are feeling is fatigue. And that is a common reason for us to make dose reductions, is overall fatigue. And then the other sort of big group of side effects that we make dose reductions for is going to be cytopenias. Olaparib, less of a cytopenia causer compared to niraparib, niraparib being probably the hardest on blood counts of this group. But all of them can cause cytopenias, and long term, they can increase the risk for secondary malignancies, particularly AML and MDS. So we should be monitoring those blood counts and the differential closely in these patients. Like I said, fatigue is very, very common with these agents, as is diarrhea, nausea, and vomiting. So we have some of the interventions that we could do down here for these different things. Fatigue being one of the most difficult side effects to really treat because we don't have a lot of pharmacologic interventions for it. We can consider stimulants or corticosteroids, but both of those come with quite a few side effects as well. So we're moving into some other targeted therapies, and Lady Gaga is going to be our patron pop singer for these, because while they all work really well, they can be a little bit hard on the eyes at times. So we'll start with mirvetuximab soravtansine, one of our ADCs specifically for ovarian cancer that is folate receptor alpha positive. And we define positivity of folate receptor alpha as greater than 75% expression on cells. So the mirvetuximab portion, like we've talked about with ADCs earlier in this presentation, is going to be bringing that payload to the site of action. So we're hoping that it's going to those ovarian cancer cells that are overexpressing folate receptor alpha. But unfortunately, we also have folate receptors in our eyes. The chemotherapeutic in here is a microtubule inhibitor. And as you may have heard in your other lectures where we talk about microtubule agents, just like the others, these can cause sort of similar class effect side effects, particularly neuropathy. So we talked about the primary toxicity being ocular. So patients need to get regular eye exams, and they have a complex schedule of topical steroids for the eyes, as well as artificial tears that they have to use throughout treatment to help prevent those side effects. Another agent, ADC, that we have in gyn-onc, this one for cervical cancer, is tisotumab vedotin. We don't have a specific mutation or surface protein that we need to check for. All of our recurrent or metastatic cervical cancers do qualify for tisotumab. And again, this is an ADC with, again, a microtubule agent attached to it. And unfortunately, this one also carries a lot of ocular toxicities. So just like with our mirvetuximab, we need to have regular eye exams, and we do topical steroids to the eyes as well as artificial tears. But this one, we have a few additional layers of interventions to help prevent toxicities to the eyes. We do a vasoconstricting drop just prior to the infusion, and that helps decrease the amount of blood flow and therefore the amount of drug going to the eye. And we use some cryotherapy. So unfortunately, for the entire infusion, patients have to lay with cold packs on their eyes to further decrease that blood flow to the eye and hopefully decrease that exposure of the agent into the eye. And we have a brand new set of agents that just came out this year. This one for low-grade serous ovarian carcinomas that are KRAS mutated. Avutametinib and defactinib are a combination of TKIs that was approved earlier this year over an accelerated approval. So we have the mechanisms of action sort of on the side there. Avutametinib blocks RAF and MEK, and then defactinib works on FAK and PIK2. So we have both vertical and parallel inhibition going on. Sort of similar idea as we had when we were talking about our BRAF and MEK inhibitors, where we're hitting different parts of that same pathway to help prevent the cell from being able to find those escape pathways or resistance mechanisms. Dosing is rather complicated with this. The avutametinib is twice weekly for 3 weeks of a 4-week cycle, and the defactinib is twice daily for those 3 weeks of that 4-week cycle. Thankfully, this does come as a dose pack, so it's a little bit easier for patients. So they have them in sort of pre-packaged sleeves to keep it a little bit clearer for them. Because as you can imagine, a 3-week on, 1 week off with differing schedules for drugs has a high risk for patients to make mistakes. Like I talked about, this combination has lots of ocular toxicity risk as well, including the risk for retinal detachment. So just like with so many of our other gyn-onc agents, we need to have our patients see ophthalmology before they get started, after cycle 2, and then every 3 cycles subsequently for this agent, or these agents, I should say, since this is a combination. And then, unfortunately, skin toxicity, just like when we're addressing the MEK and pathway with our other agents, skin toxicity is up to 94% of patients. So we do need to make sure that we have some prophylactic topical steroids, and this goes everywhere, including the face, and we give people oral antibiotics. So doxycycline is what we have defaulted into our plan, and those must be continued through at least cycle 2, but can be continued for longer based on patient response. So let's move next into sarcoma as we do our whirlwind tour of disease states. So we've got 2 agents to talk about in sarcoma. And I have them on the same slide to sort of compare and contrast. We have pazopanib, which is hitting many different receptor types. And in the biochem world, we sometimes refer to a molecule as promiscuous if it's hitting lots of different receptors. And our pop idol up at the top there, Nelly Furtado, is famous for her song Promiscuous. And she had some beef back in the early 2000s with Fergie, who had said that she was not promiscuous, much like nirogacestat, which only is affecting gamma secretase inhibitor, is a gamma secretase inhibitor in the Notch receptor pathway. However, even if we're hitting lots of receptors or we're only hitting one receptor, it depends sort of where those things fall. We can have a lot of side effects. So we see a lot of the same sort of things with pazopanib and nirogacestat. We're seeing lots of risk for hepatotoxicity. We're seeing impacts on diarrhea. Both of these can cause quite a bit of diarrhea, and that can be a dose-limiting toxicity for both. With our pazopanib, because it's hitting a lot of more of our like VEGF pathways and things like that, we see similar side effects to our bevacizumabs and agents like that. So risk for bleeding, particularly around surgery, and making sure that we're holding it so that we don't impair wound healing. And anytime we're messing around with the angiogenesis pathways, we tend to see hypertension. So we do often see increases in blood pressure from pazopanib, and often we will either need to start a new antihypertensive or increase the dose of those that are already on board. With Nero, this is just for desmoid tumors, so a relatively niche indication. Again, we're seeing lots of diarrhea, hepatotoxicity can occur. This one, we see a lot of impact on electrolytes, particularly the K and the phos. And the phos, I think, is the one that I've seen the most impacts on and can be very difficult to replace because we don't have a lot of good oral phos preparations that don't further contribute to diarrhea. We can also see non-melanoma skin cancer risk increased while people are on this agent as well. So to sort of wrap things up as it relates to this talk and our targeted therapies, we have lots of different agents approved across many different disease states. And we see these agents used not just in one place. They get approved in one disease state, and then we say, oh, let's take a look at this elsewhere to see maybe since TROF2 is amplified on lots of tumor types, it's being explored in many different cancers. So we have ongoing trials right now in gyn-onc, for example, with SASEG. So Just because we're using one agent in breast doesn't mean that you get to ignore it if you're a melanoma doc, for example, because there's a good chance that we might end up stealing it from one disease state and using it in another. Um, Combination plans always make it more difficult for us to figure out which thing was the cause. And as we saw, a lot of these toxicities overlap. So we can try to work on some timing at times to tease things out. Maybe we hold one agent at a time, like uh, Molly mentioned about diarrhea in the setting of TCHP. Is it the docetaxel causing the diarrhea? Maybe it is if it's more of the early time. Or is it the pertuzumab causing the diarrhea, which we might suspect if the diarrhea is later on? We have to be aware of drug-drug interactions. We have a lot of complex metabolism going on within the body, both at the site of action and within the liver as we're processing these drugs. We have some really nice resources available to us that can help as you're learning about a new agent, because this talk wasn't completely exhaustive of all oral chemotherapies that exist. So utilize your resources. Our Beacon treatment plans have a lot of great things in them. HOPA and ONS also have really awesome handouts that are very patient-friendly for oral chemotherapy, and they are now expanding into the IV chemotherapy world. And then a plug for your friendly neighborhood pharmacist. We are a great resource, and we're always happy to look things up with you, try to get to the bottom of a side effect, or just try to work through what might be going on with a patient who has a weird or unique side effect going on. We have thrown a lot of information at you guys. What questions do you have for me and Molly about these disease states and these medications? Well, hearing no questions, I hope everyone has an awesome start to their week. And thanks for sticking around with us and learning about these different targeted therapies. Have a great day, everyone.